a spotlight session. So a spotlight session is something a little bit different than kind of our more panelist type of grouping that we've been doing. And we have three of these spotlight sessions today. So you get to start us off with our first one. And these are about 15, 20 minutes, depending on the spotlight. And then if we have time, I'll have some rapid fire questions for you at the end. And then we get a 20-minute break. So we're doing awesome on our time. And Dr. Angela Lober, we have worked together for several years. So we also go way back. And she is truly an incredible partner through our work at Healthy Birthday and our collaborations with AWHONN, the Association of Women's Health Obstetric Neonatal Nurses. And today you are going to share some important updates about changes in fetal movement education and guidance from AWHONN and work that has the potential to really impact how we support families and promote healthy pregnancies. Thank you so much for joining us today, and I will throw it over to you.
Fantastic. Thank you so much. All right. So at AWHONN, we received a grant from Healthy Birthday by way of Iowa Department of Health, and we wanted to look at how clinics and clinicians could handle episodes of reported changes in fetal movement. And Megan, are you controlling the slides? Thank you. Okay, so why this matters, we knew from the beginning that fetal movement is a key indicator for fetal well-being. As we look more and more into the research and more research is done, we are finding that changes in fetal movement is also an indicator of maternal health. It may actually point to some maternal complications before it shows up anywhere else. We know that there's a lack of standard response to changes in fetal movement patterns, and we wanted something that was clear and evidence-based that anybody, any clinician, any provider, any nurse, anywhere could use, and like even in EDs and urgent care centers and that kind of thing. So we set out to do this process. Next slide. Count the kicks. I threw this slide in here in case I needed to reintroduce that, but I just heard in the last session folks talking about that, so we'll move on. Here's the process of what we did throughout this project. So we did a full literature review. We wanted to stay current in the literature, so we just went back 10 years. We didn't do a full sweep of everything available, just the last 10 years. From that, so we had one team working on the literature analysis. Once that was compiled, we sent it to an algorithm development team that took this literature and said, okay, what are best practices when somebody has decreased fetal movement or very aggressive increase in their fetal movement? Then we set it to a separate team, a writing team, to do the education for this. And then we had a fourth team that did education review and algorithm review. So that was our process in creating the whole thing. But then we wanted to take the algorithm and really test it. Here's a list of our folks that we had involved. Our expert stakeholders were overlooking at the whole process beginning to end. These were clinicians, researchers, advocates. We had the literature review team, as I described, algorithm and education team. So then we did a scoping review of the literature. We started off with 1,592 articles that had something to do with fetal movement. And by the time we filtered all of the way down, we ended up with 114 articles. They were primary, secondary, and review articles, even expert opinions, everything that we can find. We took out things like study protocols, letters to the editor, things like that. So out of that 114 articles, this is how they kind of broke out. There were 37 articles that had to do with characteristics of fetal movement, 49 that had to do with risk factors to changes in fetal movement, 18 on how to manage episodes of changed fetal movement patterns, and 32 on how to educate parents, the public, and clinicians. This is a lot to read. What I will tell you is like the basic takeaways from fetal movement characteristics is each baby has their own pattern, and the mom or the birthing parent is the one who is expert in their fetal movement patterns. As long as they can recognize the baseline, what is normal for their own baby, they're also the best person to identify when things go outside of normal. Risk factors included things like it was advanced maternal age, being Caucasians, antenatal steroids, opiates. Uh, there's more work on complications during the pregnancy, like preeclampsia and those kinds of things. Things that made it harder to feel the baby move. So change risks to changes in perception were things like small for gestational age, olihydramnios, and an anterior placental presentation. Education, what we found there was that it's insufficient. Like what we're doing, nothing is standardized, nothing is agreed upon. What is agreed upon is that there should be some sort of standardized education going to parents so that they can monitor their fetal movement patterns. But interestingly, and I heard in the last discussion about treating pregnant people as grown-ups, a lot of providers that we saw in the research didn't want to support educating parents because of they didn't want to increase their risk of anxiety or worry about the pregnancy. So it was an interesting finding. Management, there's still a lot to do. There's a lot of research that needs to happen, but we do know that BPP is really the best, and probably anybody with changes in fetal movement patterns should receive a modified or full BPP. So that's what we found from there. From there, we then we created the algorithm. Oh, first we did the algorithm, and then at the same time we did the education development. But we'll go to the next slide. We wrote a decreased fetal movement practice brief based on the literature because we wanted to get something out there quickly. The United States does not have a an adopted method of looking at and managing decreased fetal movement or significant increases to fetal movement. We changed the vernacular right about this point because there's some growing evidence that showed that a sudden increase in fetal movement patterns that was alarming to the parent was something that needed to be looked at. So it's not just decreased fetal movement, but it's also these really dramatic increased fetal movement episodes. So after writing this, we did change the language as we started to go through the literature more and more. So then we will go on to the next. Oh, um, there it is. The algorithm, we wrote the algorithm based on the literature. We had 19 hospital sites to test it, and this was our research project. Through those 9 hospital sites, there were 147 cases of changes in fetal movement during the 60 days that we had this out and we were collecting data. All 100% of the providers, these providers were OB docs and also midwives, 100% were able to follow the algorithm. They agreed with the algorithm course. We wanted them to stay within the hospital regulations, but also taking a look at what this literature says and how do those two things line up. And 100% of them agreed that this was a good algorithm to be following. We'll go to the next one. I'm going to go through these slides pretty quickly because I'm not watching the time, but these are the hospitals that we did the testing in. We really wanted to find large hospitals, suburban hospitals, or otherwise known as community hospitals, rural hospitals. The size was based on the number of deliveries they had per month or per year. So the majority were set right in the middle category. The gestational age and previous episodes of decreased fetal movement, we gathered that information. One thing that it said in the research is that there was an increased risk of poor outcome with multiple episodes of changes in fetal movement patterns. So we're specifically looking at that. 90% of the clients that came in didn't have previous episodes, so that was interesting, but some of them sure did. The majority were in the 37 to 48 week range. Interventions varied because they vary between hospitals and standards, and again, because there is no US adopted standard. However, we did make space for all of the options on the algorithm. Um, I'll go back into that. One of the big things was to be evaluated within 2 hours because some of this still floating ideas of how to manage this is rest, relax, drink something cold, eat something sugary, just relax, see, call us back in an hour, 2 hours, 10 hours tomorrow if you don't notice anything. And so a lot of the research did point to it doesn't matter. That is a delay in care. We don't want a delay in care. So as soon as somebody reports a change in their fetal movement pattern, come in right away. We need you to be seen within 2 hours. And that 2 hours is just it's a guideline that got put out there by one of the guidelines outside of the US, and so that's what we kept. But anyway, so um, 68% did not get a BPP, and we really, as a community, we really do need to do more research around NST to BPP. There is an old research article that said 19% of NSTs are false positives, meaning they get a reactive NST, they're sent home, and then they have a demise later on. So anyway, that's an important finding there. We can go to the next. Okay, educational outcomes. Everybody got some education. The ones that didn't were sent forward for delivery. There was one demise in the group where the baby, there were no heart tones when the parent showed up, but otherwise they either went to delivery or they were discharged with what the providers felt were adequate education. All right, so what we have out of this project is we're creating two manuscripts. The scoping review is currently under review at Nursing for Women's Health. It is a beast of a paper. We have been working on this for the past year. It is a lot to wrangle 114 different articles and correlate them all. But they have some incredible peer reviewers. So this paper is going to be amazing when it's finally done. The other article is validations of the algorithm. And so we were preparing that manuscript currently, and we'll be submitting that hopefully within the month. With all of the feedback from all of the different folks that we tested this with, we did make some changes to the algorithm, but it was more formatting, so it's easier to read, it's easier to follow visually. Along the sides, that purple line is always to listen, respect the birthing parent. And the line on the blue side where you can see the word health, it is to do a full health assessment every single time they come in with any kind of concern. We felt that those were the two most important parts. We created a whole education piece out of this. It's available now through our AWHONN site, but it is the practice brief is there. The articles will be there. We created an online education module that goes over everything that the research says, what the algorithm is, and how to use the algorithm. And then there's an additional resources that we provide there as well. And so what we hope this does is that it eliminates inconsistencies in care, that ensures patients receive clear and evidence-based education, provides the healthcare team with some structured guidance, and supports organizations in their training and their implementation of how to support pregnant families. There's all the research. That's just the research that's gone into this particular presentation. The list of 114 is somewhere else. You don't need that.
Awesome. Thank you so much. So I'll just add, because I've been part of this since the beginning too, and part of how this came about was at Healthy Birthday. I'm not a medical provider. We don't have medical providers. And we were getting calls from people saying, what do I do when somebody comes in with a change in fetal movement? Or we were getting calls from fetal infant mortality review boards, telling stories after they interview parents of loss. And, I noticed a change in fetal movement. And we know research shows there is a connection between a change in fetal movement and poor birth outcomes and things like that, and the connection between maternal outcomes. The Hear Her campaign and everything also addresses um, decreased fetal movement, a change in fetal movement and things. And so we went to experts, AWHONN, and said, you do amazing work and you do all of this great research and validation. And can you help us create a protocol of what to do? You are the experts in this. And I remember them asking and saying, well, do you have a library? And I'm like, no, what do you mean? Like the public, like there's just so much that we didn't know. And, we are so grateful. And now, you think back and, when you say US hasn't adopted a standard of care, we haven't. Like AWHONN, you led this with us. Like this is truly remarkable and true systems change work that no doubt will save lives. And I just hope that everybody listening today will go to the website and check it out. And it is true systems change work that is going to improve outcomes for generations to come. And so I have a couple quick rapid fire questions. And the first one is, what is one simple tip you'd give parents today to better track fetal movements?
My tip would be to find something that is consistent. Like the Count the Kicks is a beautiful example of that. It's super easy to use, but whatever system they choose to just watch their baby every day, once a day, same time every day, really get to know the baby's movements and what feels normal and what doesn't. And hopefully
Mhm.
they never feel what doesn't feel normal, but um, just paying attention to those
Mhm.
things and then contacting the provider as soon as something doesn't feel right. It's always better to err on the side of caution. One thing that was showing up in the literature was that parents didn't want to bother their provider. They didn't want to be seen as a high need patient or a needy patient, and that's just
Mhm.
not appropriate in this. Like, be needy. That's what
Well, and that's what they're there for. And I think,
yeah.
if we take what we learned earlier today about partners and the role of partners and the support systems and helping be an advocate, and then they can also help when the pregnant person says, I just don't know, I feel like something's off, I feel like there's a change. That partner, that doula, that whoever, that dad, auntie can come in and say, let's go in, like, let's go
Mhm.
get checked out. That is what doctors and healthcare professionals are there for. So I think that's a really big component. And one thing that you said earlier, and Lauren had said this too, around the fact that people are just assuming we don't want to tell expectant parents about
Mhm.
this in case we cause anxiety. And,
Mhm.
one of the things that we say is, we talk to people all the time about things in pregnancy and women's health and stuff. Like, why is this not something that we're talking about? And why are we taking that decision to know about it away from them? Like, they should get all
Mhm.
the information out there. So I think that was really key in the fact that you put all around the algorithm on the outside. And you say this in the stakeholder group where you say time and time again in the literature, it said, listen to the pregnant person,
Mhm.
listen to them. It just bubbled up. So I think I just hit that hard. And then my second question is for we all the systems professionals listening today. Why is it so important to take this training and how should they get started? I kind of said a little bit, but I'd love for your perspective as the lead researcher scientist on it.
For sure. Yeah. So it's all about making sure we're providing equitable care. So, if I'm in a high risk facility where I have EFM specialists and I have like all of this stuff, then that's fantastic. And anybody coming in will um, get what they need. But also in spaces where there isn't that high level of care, or maybe isn't an OB system, or an OB provider, OB birthing center, that kind of thing. Like, it's really important for anybody who might possibly have contact with a pregnant person to know that this exists, to know that where the resource is, how to find it. By getting the training, it kind of puts it into your mind what you need to do, and then having access to the algorithm when that patient shows up and says, I haven't felt my baby move today, then you grab the algorithm. Okay, this is what we need to do. And
Mhm.
it takes all of the guesswork out. It allows for very fast um, care to the patient and to the baby.
Hmm. And I know Kimberly has put in the chat like how to access the training. Do you want to share a little bit more about is there a fee and what does that look like and how any and you don't have to be a nurse to take this, right? Like we
No.
want everybody to have access to this.
Yeah, everybody can have access to it. There is a small nominal fee to get into the program. That just supports the work that we're doing around it. Um, we have had comments like this should be free, and I agree, it should be free. But we don't have a funding source that will help make it free. If you are a funding source and want to like support this program to be free for the world, that would be fantastic. But there is some maintenance that has to happen on our side and so but we kept the fee as low as possible, but it can be used to train your entire staff. It can be used to we attach the algorithm to the education, so we don't just put the algorithm out there without giving the whole background education so people really understand what those different things mean on the algorithm.
Hmm.
We found that to be very important because people were interpreting it differently than what the research was supporting. So that's why it's attached to the education, and those two things need to go together.
Awesome. Thank you so much for that spotlight session. Way to start us off with that.